Wonderful. Hopefully everyone can hear me and see me okay. I want to start by first thanking Hunter's Hope for inviting us to present this study. Early infantile Krabbe disease needs no description for this group. It's clear that it's clear that transplant is not helpful for infants who have already developed symptoms. I apologize, there we go. Now it's working. Infants with early infantile Krabbe disease who are pre-symptomatic at the time of transplant can benefit from transplant with extended life and improved neurologic status. In 2006, New York State began to screen infants for the early infantile Krabbe disease as part of their newborn screening panel. Results were reported in 2016 by Wasserstein et al. And importantly, they found that the incidence was lower than they expected. The time to transplant was longer than was originally published by Escolar et al. In a cohort of infants who were diagnosed originally due to a family history. Unfortunately, the clinical outcomes were not as positive as expected, but this may simply be due to the small numbers. In 2018, Kwan et al. Published recommendations from the New York Newborn Screening Krabbe Task Force. They recommended that testing be performed within the first few days of life, with confirmatory testing to be rapidly performed in targeted infants after that. The ultimate goal is the referral for transplant or other potential therapies to occur as rapidly as possible. And this highlights one of the major challenges to successfully diagnose, evaluate, and transplant infants with Krabbe disease. The second challenge here is to rapidly perform an extensive evaluation in a timely manner. And as a reminder, the disease-related evaluation for transplant is comprehensive. This table lists the recommended testing and the recommended order of testing. The only addition that we recommend on this earlier slide measured on the CSF is to add cytosine. We'll also discuss some additional recommendations later on. But the thing I would like to point out is that if you notice, the baby is admitted to the transplant center ideally between days of life 7 and 8, which means that between birth and that time, 1 week of age, those children have already had their diagnosis confirmed with both cytosine as a second tier test or whatever the state's specific algorithm indicates. And then all the way down at the bottom, you'll see that the day of life 21 is when we're hoping to administer transplant. So again, the list here in the interim between day of life 7 and day of life 21 includes extensive testing, evaluation, and education of the families, most of whom have no idea what infantile Krabbe disease means as a diagnosis, much less what it means to go through transplantation. So just to highlight that this is an extensive list in a short amount of time. I'm going to take one moment to just focus on what the outcomes of those infants as described by Wasserstein et al. Again, there were 5 infants that were originally identified and reported in this study. 1 additional child has been identified in the interim since then. And note that of the 5, 4 were actually transplanted. Patient 3, parents elected not to undergo transplant. And of the 4 that were transplanted, patients 2 and 5 unfortunately died early due to transplant-related mortalities. Patient 1 and 4 are long-term survivors, and at this point in time when the paper was published, they were 8.5 years and 5.5 years respectively of age. At this point now, several years later, patient 1 is 14 years old and patient 4 is around 10 years old, and generally speaking, the outcomes are the same. Patient 1 had moderate to developmental delay in all domains, but was able to participate in school, things like that, and did require extensive supports for spasticity and those overall delays. Patient 4 did have severe delays, and again, remains so at this date. So the lessons that we learned from this newborn experience, the New York State experience, were extensive. And they really did pioneer and inform how other states approach newborn screening. Namely, the initial diagnosis should be based on enzyme and cytosine levels. We've discovered that if cytosine is high, namely greater than 10 nanomolars per liter, this is consistent with a diagnosis of early infantile Krabbe disease. And I'm sure if you haven't heard the updated data in that respect to that, you will during this session, this meeting today. We learned that it's important, assuming the parents are in agreement and consenting, to immediately refer to a transplant center. There's no need for additional consults to be done in the local area. It's really important to move the patient to the transplant center as rapidly as possible to initiate the evaluation. And importantly, we do not need to wait for the results of mutation analysis while the evaluation and workup is undergoing for transplant. When the child does get to the transplant center, it's important that the HLA typing is drawn as quickly as possible after arrival. The donor selection should not delay the initiation of chemotherapy. You can identify that final donor after that you've started. And it's important to also recognize that moving the infant from the mother's insurance to the baby's own insurance policy is important. With those lessons in mind, additional states have enacted newborn screening for Krabbe disease for all infants, namely the states listed there on the slide. In addition, other states are in the process of enacting at this or hoping to do so soon. Given the challenges that we've identified and the lessons that have been learned from the New York experience, these other states have started testing for early infantile Krabbe disease in children, and to date, 6 children have been identified and subsequently diagnosed. Because of this, a study group was formed with the centers listed below, and these are the centers that are participating in this study. Nationwide Children's Hospital with the PIs Hema Rangarajan and Margie Ream, St. Louis Children's Hospital with Shalini Shenoy and Rafael Galindo, Laurie Children's Hospital, Jennifer Rubin, and then here at Duke, Joanne Kurtzberg and myself. This is a multi-center observational study. We've entered the data into a secure red cap database retrospectively and are going forward with prospective collection of the data interest listed on the slide. Our primary measures were at 1 year after transplant, and we do at this point have some additional data available for some of the patients. Consent was obtained from all parents and guardians of the infants and approved by the institutional IRB for all the centers. So again, we identified 6 infants that who came from 4 states. All infants had low GALC enzyme activity. Conversely, all had very high cytosine levels. Not only were they above the normal range, but also above the range that's typically seen for late onset Krabbe disease. 4 of the infants were referred to, for transplant in their home states, and 2 were referred out of state. Genotype results were available for some of the children for clinical decision making, but not all. Of the genotypes that we know, 3 infants had the 30 kb deletion, either heterozygous or homozygous. 2 other infants had known pathogenic variants, and 1 infant had a novel variant which was predicted to have high-risk features. That in combination with the high cytosine supported the diagnosis and the need to proceed to transplant in a timely manner. So here are the timelines for the 6 patients from diagnosis to transplant. The x-axis reflects the days old, with the 0 being day of birth, of course. So as you can see in black for patient 1 and patient 6, the families were alerted of the abnormal newborn screening results. For patients 2 through 5, they were alerted directly before the consult. So just for the ease of this particular figure, that's not indicated there. But as you can see, all infants families were alerted between days 6 and 16 of life. Patient 1 did require an additional blood draw to confirm the diagnosis. Patients 2 through 5, again, had their first contact directly within the prior 24 hours of their initial consult. And then patient 6 did have a several-day delay between initial contact and the consult. Three infants were admitted, as shown in orange, to the hospital at the same time and began their evaluation. 2 infants were admitted to the hospital for evaluation a few days later, and 1 infant had an evaluation as an outpatient. Chemotherapy started at a median of 26.5 days of life, and the range was from 14 to 32 days. For those of you who are not transplant familiar with transplant, chemotherapy typically lasts approximately 9 days, depending on the regimen used. These children all received a regimen that lasted 9 days with an extra day of rest, which led to having transplant at a median of 36.5 days, ranging from 24 to 40. As you can see, only 1 patient was transplanted before day 30, which a prior study had identified as a predictor of improved functional outcomes. That being said, we certainly have observed some successes. All 6 patients engrafted in a median of 13.5 days, ranging from 11 to 24 days. They all have documented donor chimerism and normal GAL-C enzyme activity. All are alive with a mean follow-up of 34 months, ranging up to 44 months. 4 of the 6 children have normal immune function and are off all transplant-related medications. 2 children remain on immunosuppression for autoimmune hemolytic anemia at this time. At this point, I'm going to transfer to Dr. Margie Ream, who's going to present the remaining results of our study.
All right, so I'd like to share my screen to finish out our slides. Okay, so, okay, now I can share. Okay, so here are our 6 patients, and patient 1 is the oldest, patient 6 is the youngest. So our follow-up to the current time ranges from 16 months old to 44 months old. 3 of the patients have growth restrictions. So the second row here shows height, weight, and head circumference percentiles. All of the patients are taking some nutrition by mouth. 3 of them are taking all nutrition by mouth, and 3 are supplementing with G-tube feeds. All patients have some degree of self-feeding skills and are developing fine motor skills. For language, they all have some use of language. Our 16-month-old is using single words, which would be developmentally appropriate. Our oldest patient is using 1- and 2-word phrases with quite a few words and signs and using assistive communication device. And so to use such devices, it's helpful to have good fine motor skills. And then this patient also has really strong receptive language despite the expressive language deficits. All patients have some degree of locomotion. Those that are walking are only doing so with support. None of our patients have achieved independent ambulation. Our older patients have developed increased tone in the legs, but the 16 and 22-month-old do not have hypertonia as of the state of follow-up. This slide showing the results of the Bailey scales of infant development. The figure on the left is the composite scores showing motor, language, and cognitive domains. The composite score index has a mean of 100 and a standard deviation of 15. So you can see from this that all of the patients are below a standard deviation away from the mean for all areas of development. For most areas of development. We still have, we're close to that 1 standard deviation cutoff for cognitive in some of the patients, but still below the 1 standard deviation from the mean. The figure on the right breaks down motor and language into other domains, so gross motor, fine motor, receptive, and expressive. The subscale scores have a mean of 10 and a standard deviation of 3. So we see here that some patients are within a standard deviation of the mean for some of these subscales, but most patients fall significantly below that. Gross motor is, as expected, the lowest area of development for these patients. And these scores are at the 1-year follow-up mark. This figure is showing the Lowens MRI Severity score over time for each patient, and the data represented in this figure is the mean of 2 independent neuroradiologists reviewing the MRIs at each time point, and they were blinded to the patient's clinical status. They just know the age and the fact that they were transplanted for Krabbe disease. We can see that over the first 6 to 12 months, there is worsening in the MRI score in all patients. And then in some patients, there seems to be a trend towards improvement. Also, it's interesting to note that the initial score didn't necessarily predict the final score at the current time of follow-up. Because these patients were seen at different centers, and this was a retrospective study up until this point, the neurophysiologic testing was performed per institutional protocol. So the different modalities of neurophysiologic testing and the timing was not standardized across patients. However, all patients received visual evoked potentials, EEG, brainstem auditory evoked responses, and nerve conduction studies at various points along the follow-up. We looked over this data to try to make some conclusions about how this data can be used going forward. We found that the visual evoked potentials, which in this table, we're just looking at the presence or absence of the P100 response, and the presence or absence in the pre-transplant period really did not correlate with patient outcomes. And whether or not the response was present or absent varied over time. And in some patients where a response was initially absent, it returned. And then in patient 1, we didn't get the response again in at least one of the eyes. So based on this small group of patients, it seems that a visual evoked potential is not particularly helpful for disease monitoring, but of course can be used when there's concern for monitoring the visual development. EEG was done in all patients in the neonatal period and was normal or abnormal in various patients. And it seems the EEG result also was not helpful in monitoring disease progression. It is important to note that none of these patients have developed clinical seizures. There's some anecdotal experience that if patients have spasticity and are started on baclofen, this may reduce the seizure threshold and increase the risk of having seizures. And EEG should certainly be done if there's concern for clinical events concerning for seizure or cognitive regression that could indicate subclinical seizures. But for routine monitoring of early infantile symptoms or disease progression, EEG may not be helpful. All patients who had brainstem auditory evoked responses in the neonatal period prior to transplant were abnormal and remained so for the most part during the course of follow-up. We hope to further analyze this data, and what it seems to look like so far is that the auditory evoked response, which we looked at, which was the latency between waveforms 1 and 5, although they remained abnormal, they did seem to improve and trend towards the more normal values over time. So we do believe that brainstem auditory evoked responses are helpful for monitoring disease progression. Nerve conduction studies were done in the majority of patients prior to transplant and were abnormal in all of these patients. The nerve conduction studies remained abnormal over the course of follow-up, and it appeared that the motor neuropathy was progressed over the course of the post-transplant period. The pattern of abnormality here is a primary demyelinating, but also some axonal component to the neuropathy, and it's both sensory and motor, but motor is considered to be more debilitating, of course. So we do feel that nerve conduction studies are helpful for monitoring disease progression, and we have a second manuscript plan to provide more details for the pattern of neurophysiologic abnormalities in these patients. So circling back around to what Kristin was presenting earlier, we would like to propose a slight modification to the algorithm proposed in the Kwan et al. Paper in 2018. When a state newborn screen lab receives a specimen and then performs GAL-C enzyme activity and in some cases cytosine, and we would recommend that cytosine as part of the initial newborn screen reflex testing. If a patient is diagnosed with likely early infantile Krabbe disease, referral directly to a transplant center should be initiated. This should not be delayed to get genotyping results. And patients should be referred directly to a transplant center and not to delay to be seen by a local geneticist or other specialists first. The diagnosis of early infantile Krabbe disease needs to be confirmed and should be done so at the transplant center in parallel with this transplant evaluation. Once the disease is confirmed, then chemotherapy can be initiated even prior to a donor being selected. And all of this is to facilitate the goal of receiving transplant before 30 days of age. We also like to propose slight modifications to the transplant evaluation. We continue with the goal of admission to transplant center within a week of life. There's emerging data that cytosine from the CSF can be helpful in identifying patients, and it is also now clinically available as a test through Mayo Labs, and we recommend that this be done for patients receiving lumbar puncture. The original transplant evaluation recommended MRI with DTI. We note that DTI is not available at all centers, and while DTI may provide very interesting data, it is not necessarily used in the transplant evaluation decision-making. Neurophysiologic tests should be done prior to transplant, but EEG and visual evoked potentials may not be particularly helpful in identifying symptomatic patients. The hearing and vision evaluations, or in the initial evaluation list here, are important, but not necessarily as helpful in the immediate neonatal period, and should definitely be done later on when the infant is old enough for these tests to be helpful. It's also important to note that all these patients should have had newborn screening hearing screens, so have had some degree of hearing screening even before the newborn screen result is available. And finally, the goal is still to administer transplant within the first 3 to 4 weeks of life. So in summary, the New York State experience has really been invaluable and really has informed Krabbe disease testing and referral practices in other states. I think that the state newborn screening programs that have identified 6 additional children with early infantile Krabbe disease have learned a lot along the way from the New York experience as well as from their own. These 6 children were all evaluated and underwent transplant before day 40, and all successfully engrafted and are alive with a range of follow-up between 16 and 44 months of age. They're all gaining developmental milestones, but they're all significantly delayed and gaining at a slower pace than their peers. And gross motor skills are more affected and become more affected over time. The manuscript presenting these 6 patients is in its final stages of preparation, but I think one of the most important contributions of this case series to the Krabbe community is that it was really the impetus to begin a database to start both retrospective and prospective following of these patients. And we welcome collaboration with other institutions as more infants are identified so that we can develop a more robust prospective database for these patients. I'd like to acknowledge all of our collaborators at the 4 centers and particularly thank Hunter's Hope for organizing and supporting our efforts, to the newborn screening programs, and to the patients and their families who agreed to be part of this study. And with that, I can pass over the screen back to Anna.